All right, the next one we're going to do is called the Tinel sign for tarsal tunnel syndrome. We can do Tinel sign anywhere there's a superficial nerve, okay? So when we get into the upper extremity next semester, you guys will learn a number of different locations to do the Tinel sign. We've already learned the Tinel sign at the head of the fibula, okay, for our superficial peroneal nerve. We can also do it at the ankle with our posterior tibial nerve, okay? So you want to pre-position the nerve in a taut position. So I'm going to put my patient in slight eversion or external rotation and dorsiflexion. So that already puts the nerve on stretch. Do you have any numbness or tingling?
No, I feel like I can feel it stretching now.
Okay, yeah. And if you have a patient who already has tarsal tunnel, this may be enough to elicit their symptoms. Then we're going to take our index and middle finger and we're just going to tap over that posterior tibial nerve. Dr. Dickert and I did a lot of research to try to find out if there is a gold standard for how long you do the Tinel sign, and there is not. We were inconclusive in our findings. So I typically will do from 10 to 20 seconds of tapping. If your patient doesn't elicit a reproduction of their symptoms, this is not the impairment that you need to go hunting down. Okay, any numbness or tingling? Okay. I'm not going to do it for the entire time with Kristen. She didn't come in with any symptoms, so we're going to assume that she's negative for her Tinel sign. Okay. The next one is the dorsiflexion eversion stress test for tarsal tunnel syndrome. This will look also similar to what we've already done with our eversion test and our modified eversion test, or modified external rotation test. Okay. So what I'm going to do is I'm going to place my patient in a long-seated position. I'm going to grasp the bottom of her foot. I'm going to pull her into dorsiflexion, and then I'm going to rotate her out, okay, into eversion. So again, as we talked about with a Tinel sign, essentially what I'm trying to do is I'm trying to put that posterior tibial nerve on stretch, okay? So I'm going to look for a reproduction of my patient's symptoms. Numbness, tingling, nothing, okay? If my patient presents with numbness and tingling, I've got a pretty good idea. And again, you guys can see the flexor retinaculum right back here. You can see from the drawing that this puts pressure or tension, and if your nerve is already irritated, that's going to increase the tension or pressure on your posterior tibial nerve. Okay. The next special test we're going to do is called Mulder's sign, and it's to evaluate for an intermetatarsal neuroma. Okay. So what we're going to do is we're going to squeeze the heads of the metatarsals together. If your patient has a neuroma, it will elicit pain. So as you compress over that neuroma, that elicits your patient's pain, okay? Then we're gonna grab with our index finger and our thumb the top and the bottom of the foot, and we're gonna compress right over where we suspect the neuroma is, okay? So pain, reproduction of symptoms, clicking are all considered positive for positive special tests for intermetatarsal neuromas, okay? So what I'm gonna do is I'm going to take one hand, I'm going to squeeze the metatarsal heads together. Any pain with that? Okay. Perhaps Kristen has had pain in between her second and third toe in the past. I'm going to grab on the dorsal aspect with my thumb and on the plantar flat aspect with my index finger, and I'm going to squeeze. So I'm essentially providing 2 points of pressure or contact. Again, I'm looking for a reproduction of my patient's symptoms. If there's none, then it is not an intermetatarsal neuroma. Okay. We have another special test to assess for intermetatarsal neuromas, and I negligently did not bring a pencil. Pencils are ideal because of a soft eraser, but I am going to demonstrate it with an Expo marker because it has kind of a smaller or about an eraser shot sized tip. Okay. So with this, my patient will tell me where their pain most often is. So again, we'll say right in between the second and third metatarsal. I'm going to grab the end of my pencil, and essentially I'm shoving it in between my second and third intermetatarsal joint space. Okay. If my patient has an intermetatarsal neuroma, this will elicit the same pain. I can also add a little bit of a compressive force if this is partially irritating but doesn't reproduce my patient's symptoms. All right, that brings us to the end of our special test. The rest just go into off or on-field considerations. I'm going to recommend that you guys read that through your textbook. There are a couple of slides in here that we're not going to take the time to go over, but please make sure you read it in Starkey and Brown and then come to class after Thanksgiving break with any questions. Thanks for your attention and happy Thanksgiving.